Actually, when Suma ma'am gave me the opportunity to speak in this on this day, we were like, what is an obstetrician who is only keen on fertility once the UPT is positive, doing in a fertility conference? So maybe I guess making my job easy after the pregnancy test comes positive. So we will be discussing preconceptional care before pregnancy. So what is preconceptional care? Why is preconceptional care important? Who needs preconceptional care? And when is preconceptional care needed? So what is preconceptional care? Preconceptional care is taking care of the mother and identifying the risk factors before the pregnancy becomes positive or while the patient plans pregnancy, and modifying all the modifiable risk factors and giving all the vaccinations. So why preconceptional counseling is necessary? Because most of the poor pregnancy outcomes are due to avoidable risk factors like unplanned pregnancy, maternal age, undernutrition, obesity, iron deficiency anemia, vaccines, preventable diseases, sexually transmitted diseases, epilepsy, smoking and alcohol. If we can see, all these risk factors are modifiable if the patient can be counseled at the proper time. So, who should seek preconceptional counseling? Any woman before the reproductive age or during the reproductive age. So, best time is to target adolescents as well as young adults and should be continued through the pregnancy, through the reproductive years and towards the menopausal age also, as late pregnancies are have higher risks. So, every woman should be having preconceptional care throughout their reproductive years at different points of time, because risk factors change with age and with advanced. So, when is the ideal time for preconceptional counseling? So, no woman comes for preconceptional counseling. We have to identify the times when the preconceptional counseling can be done. Like in adolescent who comes for AUB can be identified and treated for risk factors like the diabetes, thyroid, obesity, and any person, marital or not, unmarried, who is coming for MTP, that opportunity can be taken to counsel for preconceptional counseling. Women requesting for postponement of periods, like we have marriage next month, so please give me something to postpone my periods. Anybody who is coming for postponement of periods. Reproductive age girls visiting with her mom. And especially women can be identified and selected for preconceptional counseling when they come with history of subfertility. That is the time when we can address their issues and do preconceptional counseling and give care. And postpartum, before the patient gets discharged or in the follow-ups postpartum, preconceptional care can be provided. So what should preconceptional care include? Primarily, preconceptional care should include contraception. It should be the first step of conceptional care, because providing a knowledge of adequate contraception and effective contraception, avoiding the unwanted pregnancies and abortions is the first step towards preconceptional care. So, we have to educate the women about different methods of contraception and emphasis on long-acting reversible contraceptives and mechanism of action of the same can be, and need for the follow-up of the once the contraceptive method is chosen, and especially return to fertility. When is the fertility returned once the contraceptive method is stopped? Like in DMPA, the return to fertility takes up to an year. So these should be discussed. Along with this, the ideal age for first pregnancy, planning first pregnancy, need for planned pregnancy, unplanned pregnancy should be avoided, a need for prompt antenatal dating, because so many problems occur because of lack of dating of pregnancy. So need for prompt dating and immediate visit as soon as the pregnancy test is positive should be emphasized. So the second step is addition of folic acid. So in low risk women, 0.5 mg folic acid should be started 1 month before planning pregnancy and to be continued first 3 months of her pregnancy. In women with moderate risk factors, it is 1 mg folic acid started 1 month prior to planning pregnancy. And in women with high risk factors like previous neural tube defects, increased BMI, diabetes, thalassemia, 4 mg of folic acid should be prescribed. And preferably methyl tetrahydrofolate should be offered, as it also addresses women with methyl tetrahydrofolate deficiencies. So this should be preferably prescribed. Other multiple multi-nutrient supplementation is not recommended along with folic acid, and DHA don't have a role pre-pregnancy and in first trimester. So the second most common thing is anemia. Anemia is more prevalent during adolescent and reproductive age women. So every woman that comes to our OPD should be screened for anemia, and women in the reproductive age group should be supplemented with 100 mg elemental iron and 500 mg folic acid every weekly, along with deworming every 6 months. So third is optimizing the body weight management. So even underweight or mostly seen overweight and obesity have grave risk factors during pregnancy. So this should be addressed before pregnancy is planned, because once the pregnancy is positive, even if the underweight people gain weight during pregnancy or overweight people cannot reduce weight during pregnancy, it will cause more risk. In underweight, counseling about the risk factors during pregnancy. Weight gain in pregnancy does not reduce the risk associated with the low pre-pregnancy weight. Screening for eating disorders must be done, and nutritional modifications should be advised. When it comes to overweight, counseling about the risk factors during pregnancy like diabetes, hypertension, and increased chance of cesarean section, stillbirth should be counseled. And irrespective of the pre-pregnancy weight, weight loss during pregnancy is not possible. So weight loss should be advocated before planning pregnancy itself. Like nutritional modifications and strength conditioning exercises can be advised, and realistic targets like 5 to 10% of weight loss in over 6 months should be advised. So in women with BMI more than 32.5 with comorbidities and with BMI 37.5 without comorbidities can be referred to for a bariatric surgery. But once the bariatric surgery is done, then the pregnancy should be avoided for at least 1 to 1.5 years, because there is rapid weight loss and as well as malabsorption during that period. So genetics. Any history of consanguinity, any history of multiple disorders in the family, advanced maternal age, any exposure to teratogenic things or fever with rash or chickenpox just before planning pregnancy, or any ethnic backgrounds where there is high risk for disorders like thalassemia and sickle cell anemia, all these history along with any presence of birth defects in the family, or recurrent pregnancy loss, or family history of early onset cancers or other non-malignant disorders like Alzheimer's should be noted while taking the history. Preconceptional universal thalassemia screening is advocated because India is a high-risk population for thalassemia and sickle cell anemia. Universal screening should be advocated, and a woman should be advised to get HPLC done at least once in her lifetime. And when she is positive as thalassemia or sickle cell heterozygous trait, 25% of women carrying thalassemia who don't present with thalassemia have a chance of giving 25% of thalassemia major babies if the partner is also carrier. So this should be acknowledged, and every woman should be advised to get a HPLC done. Particular patient is not willing to get the thalassemia screen done, at least thalassemia screen must be done in patients with MCV less than 79 or MCH less than 27, as they are at higher risk for thalassemia. Because even thalassemia minors, they only present with borderline anemia or they may have normal HB levels. So diabetes mellitus, pre-pregnancy, everyone should be universally screened for diabetes. Like as India is high risk capital of diabetes. So fasting plasma glucose more than 126 and 2-hour plasma glucose more than 200 is diagnostic of over DM. So diabetes self-management should be taught, and importance of maintaining good lifestyle and maintaining the sugar levels while planning pregnancy should be addressed, because and the high risk risks associated with not controlling the diabetes should be addressed. So as we can see, if the HbA1c is less than 7 while planning pregnancy, the risk of anomalies in the fetus are similar to the baseline risk of the general population. But when it increases to 9.1, the risk of fetal malformations increase to 14. And when it comes to 11.2, it increases to about 25%. Means 1 in 4 babies can have fetal abnormalities. Patients with over-GM should be advised to plan pregnancy once the HbA1c goal of less than 6.5 is reached, and they have to be supplemented with folic acid 1 month before conception. So before planning pregnancy, renal must be evaluated before planning pregnancy itself. When the targets are not adequate, adequate contraception should be advised, which include combined hormonal pills or progesterone pills when there are no vasculopathies, and IUCD can also be offered with caution. So now coming to thyroid disease. So universal screening of every woman that presents to our OPD for preconceptional counseling must be screened for thyroid disease. So hyperthyroidism must be optimized before conception. If the patient is planning pregnancy within 2 years, then the surgery is a better option than radioactive iodine. But once the radioactive ablation therapies are given, pregnancy should be deferred at least for 6 months. So propylthiouracil is the drug of choice for first trimester, as there are risks of embryopathies with methimazole. But prolonged use of propylthiouracil can cause hepatotoxicity. Hence, the drug should be converted to methimazole once the first trimester is done, in the second trimester. So when coming to the hypothyroid, the target of TSH is less than 2.5. So looking at this, any patient with TSH between 4 to 10 anti-TPO antibodies must be done. Ideally, more than 2.5 anti-TPO antibodies must be done. But anybody between 2.5 to 4 anti-TPO antibodies must be done. And looking here, any patient with TSH more than 10, irrespective of TPO status, treat the patient. Between 4 to 10, if anti-TPO antibodies are positive, then treat the patient. And if there are negative, still consider treatment. And between 2.5 to 4, if anti-TPO positive, then consider treatment. When it below 4, and if it is negative or less than 2.5, routine treatment with thyronome should not be preferred. Only with history of prior losses, thyroid supplementation should be offered. Once the pregnancy test becomes positive, the dose of levothyroxine should be increased 30% as soon as the pregnancy is positive. So next, coming to heart disease in pregnancy, universal basic clinical cardiac examination should be done to every patient, and discuss the consequences of pre-existing heart conditions and the medications used for the pre-existing heart conditions on pregnancy outcome should be discussed in detail, and the approach should be multidisciplinary always. So even before planning pregnancy and patients with prior cardiac disease, a detailed cardiac assessment with a cardiologist is must to assess the baseline cardiac condition, reviewing the medication, evaluating any need for corrective surgeries so that the surgery can be done before planning pregnancy itself, and identifying women whom pregnancy would not be advisable. So genetic counseling must be done in patients with congenital heart diseases, and warfarin is associated with risk of embryopathy in 5 to 10%, but is highly effective and has better patient compliance. So risk versus benefit between converting to heparin or continuing warfarin should be discussed, and informed decision to be made. Patients having severe pulmonary artery hypertension, severe systemic ventricular dysfunction, any New York Heart Association grade 3 or 4, LV EF less than 30, previous PPCM with residual dysfunction, severe left heart obstruction, Marfan syndrome, aortic dilatation more than 50 mm, and native severe coagutation must be refrained from pregnancy. So adequate contraception with progesterone only pills should be advised. So next, coming to pre-pregnancy hypertension. Universally, every woman should be screened for hypertension before planning pregnancy, and counseling about the risks when the hypertension is not controlled should be advised, and the target blood pressure for planning pregnancy is 140/90. So like in DIM, renal disease, ventricular hypertrophy and retinopathy should be evaluated before planning pregnancy itself. So ACE inhibitors and ARBs should be avoided, and safe antihypertensives like labetalol, nifedipine and methyl-dopa should be initiated, and till the contraception is, till the target pressure levels are achieved, adequate contraception to be advised. So next, coming to epilepsy, need for planned pregnancy and avoiding unplanned pregnancy should be emphasized, and counseling regarding the risk of aggravation and effects of epilepsy and anticonvulsant drugs on pregnancy should be discussed. So phenytoin, valproate, carbamazepine, which are teratogenic, to be converted to safer alternatives like levetiracetam, and preferably monotherapy at lowest effective dose should be initiated, and stable anticonvulsant regime for at least 6 months should be advised prior to conception. So, and every patient with epilepsy on anti-epileptics should be advised to take folic acid at least 1 month prior to conception, and multidisciplinary care is mandatory. And cancers. In young patients diagnosed to have cancer, fertility preservation methods like sperm cryopreservation for an male and embryo or oocyte preservation for female should be advised. A cancer survivor should be counseled on potential of the subfertility, reproductive effects by cancer, as well as the cancer treatment should be discussed. And cancer survivors planning pregnancy should be assessed for subfertility. Level of subfertility depends on the age of the patient, type of cancer and treatment of cancer. So women with any personal or family history of cancers with associated genetic mutations, genetic counseling should be done. And breast cancer survivors should be advised not to plan pregnancy for the next 2 years when they are highest risk for recurrence. So female cancer survivors treated with chemotherapeutic drugs and radiation to the heart should be evaluated by cardiologists prior to planning pregnancy, and reliable non-hormonal contraceptives like SCRMs should be advised. So cervical cancer screening must be done according to the protocol before planning pregnancy. American Cancer Society 2020 says initiation of cancer screening at 25 years till 50 years, and primary HPV DNA testing every 5 years, LBC every 3 years, or if co-testing is done every 5 years. So next, coming to autoimmune diseases. Autoimmune diseases can improve, worsen or remain unaffected during pregnancy. These things has to be discussed, and when coming to the most common autoimmune disease, SLE women are high risk for multiple complications in mother and fetus. Hence, all the complications must be discussed, and quiescence of at least 6 months should be advised before planning pregnancy, and increased risk of flare post delivery should be discussed. And toxic drugs like methotrexate, cyclophosphamide should be avoided while planning pregnancy, and multidisciplinary care is the key. So next, coming to asthma. Asthma, there is a chance of exacerbation during pregnancy, and there is a chance of preterm delivery, FGR and malformations. So these things have to be discussed. And inhalational beta-2 agonists and steroids are the best first drugs of choice in asthma complicating pregnancy. And long-acting beta agonists should be reserved when the maximum dose of inhalational steroids are not sufficient to control the disease, and oral steroid should be reserved when exacerbation occurs. So infections, universal preconceptional screening. Every patient that comes to the OPD should be screened for HIV, HBsAg and syphilis. And target populations who are high risk for other infections like chlamydia, gonorrhea, tuberculosis and toxoplasmosis. Only high risk population should be screened for these diseases. Routine screening is not necessary. So in a HIV positive woman, dual contraception should be advised before planning pregnancy, and need for continuous combined ART should be addressed, and risk of transmission to the unaffected partner or the fetus should be discussed. And in a serodiscordant couple, if the woman is HIV positive, home insemination with partner semen during ovulation for 3 to 6 months should be considered before other methods are considered. And if the male partner is HIV positive, referral to fertility specialist, and option for semen washing with intrauterine insemination should be given. So psychiatric illnesses, these are often underdiagnosed and not addressed properly. So when underdiagnosed and untreated, the risk of aggravation during pregnancy and postpartum, and the risk of potential teratogenicity with when the patient doesn't take medication properly should be discussed with the patient, and teratogenic drugs should be avoided, and multidisciplinary approach should be initiated, and optimization of disease is mandatory before planning pregnancy. And intimate partner violence. Intimate partner violence is more prevalent than we think it is. A patient should always be spoken to in private in a confidential manner with non-judgmental outcome, and when intimate partner violence is identified, a patient should be provided with right kind of information to who to seek when there is any abuse. So substance abuse, both the partners should be evaluated for substance abuse, and risk factors associated with smoking and alcohol should be discussed, and psychosocial and pharmacotherapeutic intervention should be initiated before pregnancy and during planning pregnancy so that the pregnancy is safe. Vaccinations. Vaccinating every woman at reproductive age group and who comes for pregnancy counseling with MMR vaccine is recommended. MMR vaccine is superior to giving only rubella vaccine. So pregnancy must be avoided for at least 3 months post vaccination, but when unplanned pregnancy occurs, it is not an indication for termination. The pregnancy can be continued. So, along with MMR, hepatitis B vaccination should also be checked if the patient is vaccinated for hepatitis B. If not, even hepatitis B vaccine should be initiated. And every woman coming to the OPD should be vaccinated for HPV. And pregnancy must be avoided for 1 month after the last dose. If unplanned pregnancy occurs during the course of vaccination, then the course should be completed post-delivery. So, along with these, varicella vaccine, flu vaccine and Tdap should also be given. And Tdap and flu vaccine, if not given pre-pregnancy, must be given during pregnancy, because pregnancy is high risk for flu, and when Tdap is given, it gives protection to the fetus during the first month of life when the fetus is not yet vaccinated. So in recurrent miscarriages, recurrent miscarriage is more than 2 pregnancy losses. TSH with anti-TPO antibodies recommended, HbA1c recommended, pelvic ultrasound with 3D recommended, APLA testing recommended, parental karyotyping recommended after 3 losses, VDRL recommended, Torch is not recommended, prolactin levels not recommended in asymptomatic patient, and thrombophilia testing is not recommended. But thrombophilia testing is recommended in patients with the history of thrombosis, in the personal history of thrombosis or any family history of thrombosis. But thrombophilia testing is not recommended in RPL. So, thrombophilia positive patients should be educated about risk factors, and women with long-term warfarin should be converted to, unlike in cardiac disease where warfarin can be, risk versus benefit should be assessed. Thromboembolic disease, patients with thromboembolic disease should be converted to heparin preconceptionally or in early pregnancy. So, dental hygiene should be addressed and stressed upon before planning pregnancy. And skincare, most of people use skincare and they are unaware of the consequences of the skincare. While planning pregnancy, vitamin A, retinol and isotretinoin and minoxidil should be stopped while planning pregnancy, and mineral sunscreen should be used in place of chemical sunscreen. So, it is always ideal to have a checklist in our OPDs so that we evaluate each and every patient ideally. So, birth is not only about making the babies, it's about making mothers strong, confident and capable. Thank you.